Welcome to today's webinar entitled When TB is the Least of Their Worries, TB and Diabetes, sponsored by the Southeastern National TB Center. Today's presentation is by Dr. Richard Brostrom. Since 2010, Dr. Brostrom has served as the CDC TB Medical Officer for Hawaii and the Pacific Islands. In a prior life, he was the Public Health Director for the Commonwealth of the Northern Mariners Islands, a small U.S. affiliated jurisdiction, managing multiple public health programs, but providing direct care for TB patients and guiding the National Diabetes Program. He has worked to address the impact of diabetes management on TB case rate and case outcomes for the Pacific Islands and authored novel regional TB-DM treatment guidelines. More recently, he implemented testing for diabetes as part of the mass TB and latent TB screening and treatment projects in the U.S. Pacific Islands. He considers himself very fortunate to be associated with the public health programs in the Pacific Islands for the past 23 years. Today's moderator is Dr. Connie Haley. Connie is an infectious disease physician trained at Vanderbilt University. She has worked in TB since 2001 and currently works as medical consultant for the SNTC. Now we'll turn it over to our presenter, Dr. Brostrom.
Well, good morning, aloha from Hawaii. I hope the sound is good. I'm honored to be speaking to, as part of the series, which is just a great series from the Southeast National Tuberculosis Center for the other issues that plague our patients while they have TB. So in the next 45 minutes or so, we'll focus on diabetes, and this talk will be a little more science focused than the ones I've given in the past, because there's been just an amazing amount of new research that's being done in this field. We'll dispense here with the disclosures. The conclusions, findings, and opinions expressed today do not necessarily reflect the official position of the U.S. Department of Health and Human Services, the Public Health Service, or the Centers for Disease Control and Prevention. So let's start with a polling question. We have about 8 of these interspersed here. I'll turn it back over.
Hey, so this is Connie Haley. Dick, I'm so glad that you're here with us today. And I want to thank you for getting up so very early. It's just a little after 6 a.m. in Hawaii, and Dick valiantly got up at 5 to join the webinar and do a little background stuff. So we're going to start with a webinar, start with a polling question. Diabetes is mostly limited to higher income countries with more overweight people. So please, if you would, participants, join us and select one of the following, true or false, and we'll get to the answer in just a little bit of time. And I wanted to just remind you all that we will have time to answer questions at the end of this, so please do type in questions that, as you think of them during the webinar, and Dr. Brostrom and I will discuss the answers to these at the end of the webinar. So I think that we can probably go ahead and close the poll, Linda. Thank you.
Wonderful.
Dr. Brostrom, do you want to go ahead?
Can you share with me with the results?
Yes, I'm so sorry. So we found that the answer to the question, diabetes is mostly limited to higher income countries, is false. About 80% of individuals chose false, and about 20% responded true.
Gosh, too easy, too easy. We're going to have harder polling questions. Okay, so here is the area that I work in, and these tiny islands, beautiful places. They say that they're not divided by the water. They say they're connected by the water. Wonderful, amazing cultures, but lots of TB. In fact, if you add up the TB rates, which are much, much higher than in the U.S., the Pacific Islands would be really the 5th highest state in the United States if they were able to combine. Just after California and Texas, New York and Florida, then we'd have the Pacific. So there's lots of TB. reminder for all of us how important our work is on a global scale, and TB diabetes is a global issue. Here's a chart that always amazed me, that they're estimated to be a billion tuberculosis deaths since 1800. And even though you guys have created amazing success in the United States, most of the world still doesn't quite enjoy that great success. TB is still the undisputed king of infectious diseases. Ebola doesn't even get on that list right now. But there's a royalty for non-communicable diseases too, and that royalty is diabetes. She is the queen of non-communicable diseases. Here's a chart from this phenomenal International Diabetes Federation Atlas. You can get it on the internet. It's a great guide that comes out most years, and you can see the for each region, the very large number of people with diabetes, and you might notice a kind of a fuzzy part around the circles there, and that is the number of people who have diabetes that don't know it yet. And this is really important for us in TB. So sort of divided the next 45 minutes up into 6 portions. Well, what do I need to know about diabetes as a TB person? What's the epidemiology of TB and diabetes? What are the potential clinical implications? Is there anything a program can do about TB and diabetes? Number 5, what should I know about diabetes and prevention of TB? And then finally, some time for discussion. Here's a slide I used to use all the time with community work in the Pacific, because the typical body habitus has changed so much over time and people forget what normal is. And of course, between a changing diet that's much more high calorie now, and motorized transport and a government desk job, people with a thrifty gene hardly stand a chance, and diabetes rates really have climbed all over the world to dangerous levels. How do we test for diabetes? Well, there's really 3 tests that we use. These tests are the hemoglobin A1C, which to me is the best of the tests. It's a little more expensive. Costs typically between $7 and $12 a test. The nice thing about the hemoglobin A1C is it captures 90 days of glucose activity. It kind of summarizes it for us, and so that we have a better idea of long-term how this patient has been doing, because glucose goes up and down all day. It's low at night, it's higher during the day. Highest is about 2 hours after lunch. The other test that sometimes uses a fasting plasma glucose, of course, the patient by definition has to come in not having breakfast, which is already trouble for lots of patients, but it is an accurate test. And the last test there is the oral glucose tolerance test, which still was considered one of the gold standards, and it's now sort of falling out of favor because that requires a patient fasting 8 to 16 hours. They come in, you give them a 75-gram glucose load, and then check their sugar 2 hours later. It's a big hassle and really unwieldy for any kind of a typical diagnosis in a clinic setting. So as I mentioned, diabetes is now a global problem, over 420 million. With diabetes, the global prevalence was estimated to be around 8.5%. So already almost 1 out of 12 adults in the world is a diabetic. That's stunning, isn't it? 1 out of 12 adults. And in 2012, diabetes was the direct cause of 1.5 million deaths, will be the 7th leading cause of death projected. And here is again, an earlier atlas from the IDF. And what I showed this one because this one was from around 2008, and you can see the projected 2030 numbers there in blue. And what's interesting is most of those numbers have already been exceeded in 2018 and 2019. So their estimates are a little bit scary and almost always a bit of an underestimate. We've already reached those, unfortunately, those 2030 goals. Let's go to question number 2. I'm handing it back.
Okay, participants, this is your chance to respond. In the US, most people know that they have diabetes. please choose true or false. And Linda, I think we can go ahead and close that poll. Got about 2/3 of people voting. So what our response rates are here, Dr. Brostrom, about 92% of individuals have responded false, and just a few have responded true. So let us know, do most people in the US know if they have diabetes?
We tricked them this time. They all understand the point already, though, and the point is that many people do not. Actually, most people do know they have diabetes. The estimated amount of people in the United States who don't know they have diabetes is around between 30-35% or so. There's various estimates, but it's pretty close to 30 or 35%. Some of the interesting possible aspects are that that rate could be higher, for example, among foreign-born, among people that don't have insurance, among people that are disenfranchised with the primary care systems, which all adds up to it could be higher among people who have TB. So globally, about half the people with diabetes do not know they have it, and this obviously is a problem. And the other point I'd like to bring up here is that diabetes is common in low and middle income countries. You guys nailed this question already. And 4 out of 5 people living with diabetes actually live in low and middle income countries. It's not a disease of the rich anymore. And this is important for places that have where TB is not well controlled. Finally, and importantly, diabetes is expensive. Not a little bit expensive, but really expensive to take care of. And in places that have fragile healthcare systems, like in the Pacific, it really begins to tug on the fabric of Pacific Island cultures. Here you can see in the Pacific Islands, these astronomical rates of diabetes. These are step surveys that are done, highly accurate, reproducible studies. And you can see rates of diabetes are very high. This doesn't come as a surprise for many of you who've been hearing us talk about this in the past. But the rates are actually so high that the Pacific Island health systems and governments have declared regional emergencies. They're using preparedness funds and trying to use disaster funds rather than for tsunamis and for typhoons to manage this burden, this tsunami of diabetes. So far, it's been a fairly unsuccessful battle. I put this slide in to remind me that diabetes isn't just about weight gain. Diabetes is about poor access to food. It's about unsafe neighborhoods where people can't exercise. It used to be a disease where it was just about food excess, and now it's more about food insecurity. And we need to remember that because, well, let's ask polling question number 3, and then we'll get to it.
Okay, thank you so much. So audience, please respond true or false. Because diabetes is common, people with diabetes do not experience stigma. Gosh, you guys are voting so quickly now.
I
Linda,
think this is a softball question. Too easy, too easy.
Linda, go ahead and close it. And
The
yes,
curve's going to be high.
Yeah, 87% of respondents chose false and only 13% chose true.
Well, of course, people with type 1 and type 2 diabetes do experience stigma. It's important for us to remember that in TB clinic. Most widely reported forms of diabetes-related stigma were folks thinking that there's just a weakness in character, a failure of personal responsibility, looking down on them as a burden on the healthcare system. And interestingly, some studies have, one study at least showed that stigma actually has an impact that's important, because those that felt the most stigma also noted that it was associated with elevated A1Cs, and they had more difficulty controlling their blood glucose variability, which some of what was attributed to their stigma. We know about stigma. Okay, let's move on. Number 2. What is about the epidemiology of TB and diabetes? we could spend a couple hours talking about this. I'll try really hard not to. Let's go with polling question 4 first.
Okay, so is the number of TB cases attributed to diabetes globally is 1, about the same compared to HIV and tobacco, 2, much lower compared to HIV and tobacco, or 3, much higher compared to HIV and tobacco. So polling is underway. Looking forward to hear you discuss this one, Dr. Brostrom. Linda, go ahead and close the poll. I will let you all know. It looks like from our responses that about 23% of respondents have chosen that diabetes is about the same compared to HIV and tobacco's impact on TB cases. About 66% chose that it's much lower, and 71% of respondents chose that the effect of diabetes on TB is higher compared to HIV and tobacco. So Dr. Brostrom, would you discuss this for us?
Sure. I think the correct answer is A, but the concern for many in the TB community is that it's going to be C. But right now, here's something that Knut Longroth put out with Ken Castro. This is a little bit dated here in 2010, but they looked at the what's called the population attributable TB rates. I'll circle those in gold. And what you can see is that the contribution to TB cases around the world is fairly equal when looking at HIV, when looking at smoking, and when looking at diabetes. So we forget these appreciated TB progression risk factors, not HIV, of course, which is prominently and appropriately number 1 on our list. But there are some other very important TB risk factors that we really need to remind ourselves are contributing to the global burden of disease. So a newer WHO estimate is that 15% of the global burden of TB is linked to diabetes. Look at that. That's 1 out of 6 or 1 out of 7 cases of TB in the world is likely related to the fact that that person has diabetes, which has accelerated the progression to disease. This is dominated probably mostly by the Asian countries. This is not true in Africa, but on the global scale, this seems to be what's happening. Now, diabetes can complicate TB treatment. We'll talk more about that and lead to poor outcomes. Medications are difficult to, but not as bad as you think. We can do this. Individuals with both conditions require careful management. There's no doubt about that. And then it's important, as we mentioned already, that 70% of new diabetic cases are in low and middle income countries, undergoing rapid economic, social, and lifestyle changes, burgeoning middle class, and places where TB is also, unfortunately, poorly controlled and quite common. Polling question 5.
Okay, you guys are doing fantastic so far. So which of these reported TB risk factors is most common in the United States? Contact to an infectious TB case, TNF-alpha inhibitor use, HIV, or diabetes? Which of these reported TB risk factors is most common in the United States? All right, Linda, would you mind closing the poll, please? So our responses, we have about 58% of respondents chose diabetes. Is it diabetes and TB talk? HIV about 13%, TNF-alpha inhibitor use 2%, and contact about 27%. So Dr. Brostrom, which of these risk factors is the most common in the United States?
Well, it is indeed a diabetes. So here at home, looking at our rates, I think there's a couple of issues that have created the situation where diabetes is the most common risk factor. First of all, here's our cases from 2017, and note the large number of cases that come from Asia. Okay, that's sort of the largest group, kind of by far, the largest source of TB cases in the United States in terms of ethnicity. And this fantastic table that gets put out by the surveillance team at CDC every year. I love table 23. I loves me my table 23. So here is a table that shows us that indeed, in terms of reported risk factors, of course, if being foreign-born is the most common risk factor, but in terms of progression, diabetes, and on this medical risk factor table, diabetes is number one, kind of by a lot, actually, and which is remarkable because we're not testing for it in most places routinely. And interesting, there's quite a discrepancy between the U.S. born total of 14% and the foreign born total of 23%. So you can see that diabetes is much higher in TB cases who are foreign born, okay? Moreover, if we look a little bit deeper, we can see in the Asian population that's U.S. born, there's a remarkably low number of people with diabetes. But among the foreign-born people from Asia, we see a 25%. So this is even larger discrepancy, where the Asian foreign-born individual really is the TB is driven there by diabetes. And of course, let's not leave out our Native Hawaiian and Pacific Islanders, because we always break the record there. A reminder: this doesn't include, unfortunately, are cases that we diagnose in the U.S. Pacific Islands. They're not in this table. So diabetes is associated with U.S. TB cases. It's the most commonly reported risk factor for progression. It's associated with 20% of all U.S. cases. And folks, I think this number is way too low. I think if we use the denominator of adults only, which is actually more appropriate, that number would increase by probably about 15% of what it is. So it would be a little bit higher, maybe 23, 24%. And the number would also be higher if testing for diabetes was required. We know that many of these people don't know that they have diabetes, and we're not discovering that when they present for TB. So diabetes is reported with more TB cases than all TB contacts, all HIV, all homeless, all TNF-alpha combined, put in one spot. Diabetes is still the winner. So let's keep that in mind when we're managing our patients. Here's a very poor attempt by me to see which states would be sort of the high-risk states, depending on where you're listening from. Which ones are going to likely have a bigger mix of TB and diabetes? And we made I showed this a few years back. Absolutely no science behind this one. So please don't interpret it as being hard science. But luckily, the surveillance team comes through again from CDC, and we look to see that the table 35 loves me my table 35. And here we're looking at risk factors for 2017 by state. And we see, I resorted these by state. You can see Hawaii leads the pack here. And I'm not so sure that this table is a result of what I plotted back here. I think more that this table is a result of which states have the most Asian foreign-born individuals coming in, and which states are testing for diabetes as people come in. You see there's some smaller states. We'll call them outliers. Okay, warning. Here's, we're at 20 minutes, third of the way through, I hope. This is why science teachers should not be given playground duty. My sister's a teacher. She sent me this one. Polling question 6. We're coming up to a science question, so I promise we'll limit my immunology slides just to one.
Dr. Brostrom, I did love your cartoon. Okay, audience, here we go. How does diabetes affect the immune response to TB infection? First choice, diabetes decreases the immune response to TB infection. Second choice, diabetes increases the immune response to TB. And third choice, diabetes has no effect on the immune response to TB. So, gosh, you guys are responding so quickly. Linda, we can go ahead and close that poll.
We're going to trick them on this one, I'm sure of it.
Okay, well, let's see. Well, 91% of people said that diabetes decreases the immune response to TB.
I knew it.
And 8% said that it increases, and 1% said no effect.
Okay. So. Finally, we got them. So this is sort of the platinum quality question, okay? And I would have gotten this wrong 5 years ago. But the work of people like Hardy Kornfeld and Blanco Estrepo in their groups are doing great work, brilliant stuff. Makes my head spin around when I see their charts and graphs. But I'm always asked about this question because, you know, association between TB and diabetes doesn't necessarily imply causation. So they're looking for real causes by improving biologic plausibility. And what we've found so far is that, to summarize, there is the diabetic monocyte doesn't behave properly. It does indeed have slow chemotaxis, slow phagocytosis, that the TB has a real advantage against the diabetic monocyte. There's delayed recruiting for other macrophages. But inside that cell, things are really cranked up. There's very high cytokine production, high interferon gamma, as we know, and that the diabetic response is actually a hyperreactive immune response. These cells are not asleep. They are definitely cranked up. So they're responding to those antigens. And the trouble is, it's not effective for killing the TB. And worse, it can contribute to poor TB outcomes. This overzealous, poorly targeted, hyperreactive immune system can lead to cell damage, further additional lung damage. And this is probably where drugs like metformin begin to have their effect, and this mystery of why metformin seems to have this magical effect on TB is beginning to be peeled by researchers like Hardy and Blanco. Okay, I promised that was it for immunology. So let's go to the potential clinical implications of TB and diabetes. So I divide these up into 4 implications. And this is true for all of the risk factors that can affect TB outcomes. Let's start with TB progression. Everyone knows that diabetes causes TB. I'll try not to belabor this point too much, except for one issue, and that is this is a lot more complicated than we thought it was, okay? So unfortunately, this changes. The risk of going from active or from TB that's latent to TB that's active is different in different locations, depends on the milieu of TB in the country of origin, the glucose control. We all want a number, but unfortunately that number is actually quite variable. So here's a great study done with Megan Murray's group at Harvard and Megan Baker, and they looked at complications, people who had complications of their diabetes. Basically, the longer you had diabetes, the more complications, the more strokes, heart attacks, amputations, end-stage renal disease, etc., the higher was the risk of getting TB. So that's not surprising, but the worsening diabetic will have an increased risk of getting TB. And moreover, as we look at diabetes control, and we also know that it's highly variable by location. In England, the average A1C on the street is 7.6. That's actually pretty darn good control. In the US, we actually can beat that a little bit for those that are insured. For those without insurance, the A1C is farther up, closer to between 8 and 9, which is not good. In eBay and the Marshalls, our average A1C was 9.3. That is pretty bad. That correlates to an average glucose of around 240. So when we look at the risk of progression that we're talking about, this was really sort of the Bible. This is the best study that was done and was really helpful for all of us in the field. So again, Murray's group at Harvard looked at risk progression, and they sort of settled on a number of 3.11, but you can see there's a lot of heterogeneity there in that data. And they explore that heterogeneity with this table, which I think is really important for us. So basically what we're looking at is, if we look at the background TB incidence, if the country has more than 100 per 100,000, the effect of diabetes on TB is remarkable. It triples the rate, 3.3. Whereas if it's a moderate incidence country, that effect was less prominent, or in a place like the United States where the rate is less than 10, you see a definitely diminished progression risk. And I think this is some of the reason why we don't appreciate globally what diabetes is doing to the TB epidemic. Moreover, if we look at area where people are from, you can see at the bottom there, in North America, among non-Hispanics, non-American Indians, that rate is pretty low at 1.2, only a 20% increase of going from latent disease to active disease. Whereas in Asia, that number is actually at the global average of 3.1. So it's complicated, unfortunately. When we looked at a cross-sectional study in EBI, and we did mass screening for all the adults there, what we found was the unadjusted odds ratio here was 3.2 in the specific island, and which is fitting, quite fitting for a very high incidence area. But we also found we could subdivide that risk. So EBI reports a TB rate of around 380 or so at that time. And when we did our active case finding, as usual, you find a lot more cases. And that rate was about 700 per 100,000. So this would be one of the highest rates in the world among the non-diabetics. But again, this is active case finding, not passive. But interestingly, in one of the few studies that have demonstrated that pre-diabetes increased that risk of TB. For diabetes in good control, so this is someone that doesn't have pre-diabetes, but actually has diabetes, that rate was almost 1.5%. And when that control began to break down between 8 and 9 for an A1C at the time of screening, the risk was 2.4%. And if they were the double-digit diabetics, we call them, with an A1C greater than 10, almost 2.5%, almost 1 out of every 40 had active TB. What about clinical presentations, smears, cultures, and x-rays? Do diabetes cases present differently? Do they have more smear positivity, more culture positivity? Is the x-ray different? The answer, of course, is yes. The quick answer is yes. And it's pretty consistent that among people with diabetes and TB, the TB may progress faster with higher grade smear and culture positivity. This is from a brand new guide that's come out from the union. I think we're going to attach it to the talk for you folks to download. This is a clinical guide that was put out by Tony Harries and his group at the TB union. Interesting, but not surprising, the severity of TB at presentation is related to the degree of uncontrolled hyperglycemia. And important to note that active TB cases can present with altered symptoms. Their autonomic neuropathy is present. They have a slower fever response. They're less likely to have night sweats. It's more difficult for a person with diabetes to have sweating. Even the cough reflex is muted, and so the diabetic patient can have sneaky, subtle symptoms, unfortunately. If you look at the X-ray, there's been lots of discussion, and the word on the street is that you're going to have a lot more lower lobe disease. Kelly Dooley did a nice review. She and Dick Chase in this group at Hopkins always are doing great work with TB and diabetes. It's a higher burden of TB disease by chest X-ray. So they come in, and this X-ray corresponds to what you see with the smear and the culture. It's more likely to be positive. There's a higher risk of cavitary disease. Really look for that in people that have TB and diabetes because it matters with your choice and length of treatment. There's a higher risk of having bilateral infiltrates. And then this idea that more diabetics or people with diabetes, possibly have a higher risk of atypical lower lobe disease. I think we see this, but it's the data doesn't really support that this is a strong finding. So there's quite discrepant data in this. In general, though, I think we have to look and be more suspicious for TB in a patient that has a lower lobe infiltrate, especially if they're not having lots of symptoms. Okay, let's look at TB treatment now. Culture conversion, drug levels, drug resistance. Does diabetes affect these? Well, first of all, there's a higher burden of TB disease at the presentation by chest X-ray and culture. So it stands to reason that there would be longer sputum culture conversion times. And that's pretty consistently measured, that folks with TB and diabetes do have a longer conversion to sputum, of their sputum and their culture. But by the second or third month, most patients with TB and diabetes will have culture conversion rates that are the same as those who are non-diabetic, okay? So that it may have less to do, these slightly delayed culture conversions may have less to do with the poor immune response or possible low INH and RIF levels, and maybe more related to their presentation of having a high burden disease at presentation. There's still good work to be done in this field. Which brings me to, this one's always a crowd pleaser, right? Therapeutic drug level monitoring. Well, there'll be lots of questions for this at the end, of course. I'm by no means an expert in therapeutic drug level monitoring. In general, we don't have it available to us routinely, especially in the islands. But people with diabetes do have lower levels of medications due to diabetes meds, increased body weight, malabsorption, and gastroparesis. And a few years back, there was a study in Indonesia. It kind of surprised us all because rifampin levels were half of what we expected in diabetic patients compared to patients without diabetes. So those levels were low, but when they corrected for body weight, it looked like it was less of an issue. And in continuation phase, it became less of an issue. A recent study was just done again by Kelly Dooley in India with over 200 patients, and over 100 had diabetes. Pretty intensive protocol, and there's good news and bad news. And the good news was that diabetes did not lower significantly the INH and the RIF versus those that did not have diabetes. Okay, that the INH and RIF levels were not lower in diabetic TB patients than they were in regular TB patients. That's the good news. The bad news is that everybody had low levels. It's sort of a universal phenomenon that the INH and the RIF was too low. There was even a look at outcomes, and she found that the drug concentrations didn't necessarily predict the poor outcomes, only the severity of TB at the time of the diagnosis. So this is sort of, I know some of the states are doing this, which is awesome. I think there's a lot more information and guidance we're going to have about TB drug level monitoring when you guys publish your papers from Tennessee and from Maryland and wherever else we're doing routine drug levels for patients with diabetes. For me in the Pacific, this is what I worry about is, and Dr. Balmer and I are going to be discussing this at our next regional meeting. Should we really increase the dose of RIF routinely? This is what I want. I want someone to tell me that if I have a patient with diabetes, that they should have a higher risk of rifampin. And the data just doesn't really quite point to that yet. Luckily, as it turns out in the Pacific, we're already doing that. Because if we look at this fixed dose combination, which is what we use in many of the Pacific countries, if a patient is more than 150 pounds or so, they actually do get 5 tablets. And I know the programs are doing this, which means that they're getting already 750 milligrams of RIF, and they're getting 375 milligrams of INH routinely. So hopefully, sort of by default, we're already dosing these drugs better globally than we may be in the US. What about drug resistance? And when you talk about low levels of RIF, everyone's worried about drug resistance. And to this, I have to say that I was kind of a doubter. And here things have changed in the past 5 years. I think the evidence just wasn't very good for this in the past 5 years, very mixed. But with the concern is that with elevated relapse rates and higher burden of disease, prolonged culture positivity, maybe lower RIF and INH levels, everyone's worried about the risk of MDR and TB and diabetes. And again, there was inconclusive studies initially, but a recent meta-analysis of 24 studies in 15 countries has demonstrated that that risk is actually significant, maybe double the risk of MDR TB. And there seemed to be no publication bias detected. Here is their force plot here, and you can see that the overall risk is around 2, but almost all of those studies demonstrate a risk that is above the one line. Many of them cross the line, but it seems to be fairly consistent of late that MDR-TB is related to diabetes. So look for it in your cases with diabetes. Really try to get a good sample for culture so that we're not treating in the dark. Okay, what about outcomes? So the smoking gun here came from Megan Baker and the Harvard group that did a nice meta-analysis in 2011. We've been waiting for this one for a while, and it showed us that the relapse rates were higher. Here is the rates of relapse in TB and diabetes. Again, this is a global number, not a US number, and that number is around 4 times higher. So the TB diabetic patient has 4 times higher rate of relapse. That's really significant, isn't it? And when we looked in the Pacific Islands, we see that same, close to that same number of increased risk of relapse. This is a little bit complicated, but basically, when I looked to see when those relapses occur, there's quite a phenomenon that occurred, and that at 10 years, the relapse rate for persons with diabetes and persons without diabetes was really the same, and that 80% of the excess relapse rate occurred early post-treatment, which lends me to believe that maybe they weren't done being treated at 6 months when we were treating them then back in 2010 to 2012. How about the ultimate bad TB outcome? One we probably don't talk enough about is age-adjusted death rate during TB treatment. And the diabetes folks at CDC wanted to remind you that people with diabetes are fragile, and that they're expected to have a higher death rate regardless of whether they have TB or not. But here, looking at people with TB and diabetes, their survival of treatment was decreased remarkably. The death rate of all-cause mortality here is 5. Now, this is the 4 studies that were age-adjusted. The meta-analysis included a whole bunch of other studies and found a number of 2, but those were not necessarily age-adjusted. So you'll hear in the literature somewhere between 2 and 5 as the increase in mortality among these patients. Either way, TB diabetes patients are fragile and they need additional support from the program. If you look at the new guidelines from the union, they're talking about making sure that patients who've had any cardiac issues, that they're placed on aspirin, or make sure that the primary care doc puts them on aspirin or a statin if they need it, because lots of that excess mortality is early in treatment when there's a sort of a hyperthrombotic state in the TB patient. When we looked at mortality in the Pacific, it was also quite high. I think there's a new study that Lori Armstrong and her team has put out through CDC, and we'll have to wait and see what those results are from the US. So to summarize, diabetes increases the number of TB cases. They're harder to diagnose. They're a little sneakier. They're harder to treat, but we can do it. And there's increase in recurrence and increase in risk of death during treatment. That's all bad news, but we can handle it. Is there anything a program can do about TB and diabetes? Yes, of course there's things we can do, but there's also things we can't do. And that is, we can't be asleep at the wheel. We're driving this TB program, and we need to make sure that we are identifying these cases. The cases are out there. And after we identify them, the question is, what are we going to do next? Well, in TB, we love our guidelines, don't we? That's how we roll. Diabetes should learn from us, actually, I think, because we're great with our guidelines. And here's a brand new guideline I mentioned earlier from Tony Harries and his group. And, I think it came out in October. In the Pacific, we've been using guidelines since 2006. These guidelines were updated with Curry Center's help in Gisela and Masai in 2010. We've continued to change them. We're at version 3 already, and this is what we use in the Pacific. I think it's helpful for all of us, though. So let's take a look at it. The first standard just talks about testing. So we have to know that these patients are, whether or not they have diabetes. And some of the states I know are doing this routinely now. I don't want to emphasize this point. The other thing to remember, though, is that TB causes an elevation in glucose all by itself, irrespective of diabetes. So it's important that if we're surprised by the abnormal glucose values, you may want to verify them. You may want to test them again in a month or so. We also know rifampin can elevate blood glucose, and people that are sort of borderline with their diabetes might really break out in full-on diabetes during TB treatment, and we should let their primary care docs know to manage the hyperglycemia if that occurs. Here's a classic phenomenon here. When I came to Hawaii, the rates were much lower than I saw in the Pacific, much lower. And I worked with Derek Felix there, and we began to institute a routine A1C testing at TB intake. It's partially implemented in 2012 and 2013 and 14. The rates went high and stayed high between 38 and 41% for our patients, with adult patients that have TB, also have diabetes. Your number is probably not going to be quite that high, but it's higher than you think. And important to remember that testing when they're between 20 and 30 is probably not high yield, although so many of these patients don't know they have diabetes. It may be worth it. But as they get older, you're going to find more and more patients that have diabetes mixing with their TB. This is not Hawaii data. This is all the Pacific Islands, where you can see 70% of people over age 50 with TB also have diabetes. Again, often TB is when people find out they have diabetes. It's a bit of a shocker. Okay, what should the doctors do? So that's what the screening. We should, maybe put the A1C in your admission packet when you're checking the creatinine, you're checking the liver function tests. Add an A1C in there if you can get it past your administrators and get it approved. What about the clinicians? What should you be doing when this patient comes back into clinic? First of all, make sure those TB meds are properly dosed. The easiest is to make sure you check the creatinine and adjust the frequency of PZA and ethambutol. This is standard stuff. We're all doing it, but you'd be surprised at how many folks have forgotten. They're not really looking to see if that creatinine clearance is above 30, and they're missing this one, and they're on too high doses or too high a frequency of PZA and ethambutol. Make sure people are on B6, of course. And then look closely for TB treatment failure. If our TB patients with diabetes they can have trouble absorbing some of the meds. This is why some of the states are doing INH and RIF levels. Adjust those levels if you can get those tests done. Make sure you adjust the level if need be. In the Pacific, we've added that metformin appears to significantly improve TB diabetes survival based on a couple of studies. And they should manage the complex interactions between TB and diabetes meds. Finally, we need to assure the cure in the Pacific, and that means for us, we consider strongly extending treatment to 9 months for persons with diabetes, especially with cavitary TB or delayed sputum clearance. This is a great chart from Heartland that was put together in 2012. Might need a little update, but it's still really useful for us. And really, there's just a few points for this. This is a chart that talks about the drug-drug interactions in the patient with diabetes who's taking rifamycins. And I'll summarize these slides with just 3 short points. Number 1, metformin is good. Okay, there isn't a lot of interactions. It's the first line drug that's recommended by the ADA and by International Diabetes Federation. So your patient with TB, if they have diabetes, should be on metformin for the diabetes. I don't expect, obviously, the TB program to get involved with that, other than maybe a note to the primary care doc. Pin it to the shirt of your TB patients and send them over to their primary care doc. Number 2 is there's one medicine really that causes trouble, and that's glyburide. Glyburide levels are decreased remarkably with rifampin. It's much less, and people will have a blood sugar that goes high. It's a long-acting, so it's hard to adjust this up high, or it's a little scary to keep giving higher doses of glyburide because it lasts so long. So in general, my patients with TB and diabetes, I try to get them off glyburide. Glipizide works much better. The the interference is much less. And remember that these medicines are found in combination tablets as well. But for the rest of these, and there are a lot of them, okay, they are in general okay to use with rifampin. And the recommendation here is just to increase the monitoring, adjust the dose if you see that that something needs to be adjusted. In general, you can press on with TB care in patients that are on diabetes meds. I heard tell of a whole community clinic afraid to give their diabetic patients TB prevention, afraid of using 3-HP because they don't want these interactions. I think that's a real loss of an opportunity to provide prevention to people with diabetes. Okay, I've talked way too much. Let's go to question 7.
Okay, so I want to just congratulate you, Dr. Brostrom, because I think you now hold the record for the highest number of participants we've had in our webinar series. We've got over 463 patients on the GoToMeeting, and then there's probably some other people who've called in or sharing, watching together. And I feel confident that all this wonderful information you've given us is going to be picked up by many more who watch the recordings later. So, so here's the polling question. According to CDC ATS guidelines, TB treatment for persons with diabetes should be extended to 9 months. The choice options are true, false, or it depends. And I think, gosh, people are responding quickly again, so we can go ahead and close that polling question. And I've got about half the individuals have put true and about half have put it depends. We want to discuss the answer?
Yeah, half of them are right. And I think the answer is it depends. Even in the Pacific, it depends. So the older guidelines said you had to have cavitation and positive cultures to extend treatment. The newer guidelines specifically say consider prolonging treatment with either cavitation or a positive culture. So that actually gives us a bit of a green light to extend treatment for people that have cavitation or a positive culture. Don't have to have them both. And that recommendation continues along with HIV, tobacco, low birth weight, immunosuppression. But the further down in the new recommendations, they do mention that some experts suggest extending duration to 9 months, regardless of the culture result, but in those that have poorly controlled diabetes. And that, again, a little bit more of a green light to extend treatment if we feel the patient's not responding perfectly. Again, when you do extend this, it should be the continuation phase, not the intensive phase that's extended. So for us in the Pacific, we sort of do the concept is that if your patient is doing really well, they have good response, the x-ray is non-cavitary, the sputum clearance occurs, then it's okay to treat them for 6 months, presuming their diabetes is also in good control. The trouble is very few of the cases will fit that category. So when we look at our cases in the Pacific, we see that this is the chart of folks that are treated longer than 8 weeks or 8 months. Indeed, we have been able to extend routinely our treatment for people with diabetes and cavitary disease, diabetes non-cavitary disease, and we do see a response of people that have no diabetes and cavitary disease. That's probably we need to improve on that in the Pacific, and then the standard treatment. Okay, those were the clinical issues, and we're happy to have those dispensed with. It's actually not that more, there's only a few little wrinkles in clinical management that we can handle that. Now the platinum standards, okay, these are sort of where things get a little bit kumbaya, and we're actually sort of going to talk to the patients about their diabetes. We may even use DOT visits to help persons manage their diabetes. These are a little bit more aspirational, and typically when we show these, the anxiety level of the TB nurses begins to rise. And so as the TB anxiety level rises, I'll go to this slide, which means I've been talking too long. Let's all stand up for a second and turn around. I'll have a little Richard Simmons moment. Put your arms out, stand up, stretch. We're in the home stretch here. Touch your toes if you still can. Okay. So here's a TB nurse that I like to say she's doing DOT in front of a whole bunch of patients in 1911. This is DOT. Of course, there were no medications then. Just improving survival by isolating patients, by improving diet, and by this remarkable thing called exercise. And telling TB nurses to start talking to patients about diabetes increases anxiety because we're not really geared for that. But it's important to, if you have the right tools, it's a lot less anxiety provoking. So, way back in 2012 or so, we finally finished this key messages for TB and diabetes. And this is something we use in the Pacific as a teaching aid for talking to our patients who have both conditions. And this is available and free, and it's been translated in several languages and used by several states. I know New Mexico has done a redo. I think Maryland has a redo. Indonesia has a redo. Mexico does. So this concept is caught on, and I'm sure the new versions are much better than this first version. We try to stick to just TB issues in the first month. And the DOT worker, when sitting down with the patient, can go over some of the basics like a standard flip chart. We have the messages on the back that can be read, just pictures, big pictures and few words in the front. And then after the first month, it's time to sort of drop it on them that, oh, by the way, you have TB and diabetes. Of course, they know this, but we don't emphasize this till we've had a solid month of TB treatment. And then the guideline goes through just the low-hanging fruit, just stuff we can do about lifestyle changes. The only mention of medications in this whole guide is to remind patients to go to their doc and take the meds that they've been given. That's not our job. That's where I draw the line for our patients. All right, I think this is our last question, right?
Sorry, I had a little challenge unmuting. This is our last question, and we tried to have a little bit of fun with it. So to the audience, please feel free to be really honest with the answers to this question. It does indeed provoke that anxiety like you were talking about, Dr. Brostrom. TB physicians and nurses can improve a TB patient's diabetic control. Select one of the following. Sure, whatever it takes to help my patient. Love to, but I'm already overloaded. I'm not comfortable with diabetes management, or have you lost your mind? So just give them a few more minutes. Dick, that tool that you were just showing really was excellent. So you said that's something that people can access online. Is that link at the bottom of the slide the best way to get that tool, or do they have booklets produced that could be sent out?
Well, I'm not sure that the Pacific Island one is the one we want to be pushing, because I think it's been made better. Let's after the call, we'll talk to the folks in New Mexico. I think they've got a nice tool. There may be others in the U.S. This one is, at least last year, was available online. There have been some issues with the artwork and whether it's free and downloadable. So let's make sure that we get this out to the folks who are online.
Okay, great. Hopefully if we find this resource, maybe we can post it with the final version of this. But you please audience, feel free to reach out to either one of us if you are looking for tools like that in the future. So let's go ahead and close the poll, and thank you, Linda. So a large proportion of participants are saying, sure, whatever it takes to help my patient. And that's really, I think that's just the essence of public health workers, that they are always willing to try to do what they can, even when it is adding to already overloaded schedules. And the reality is we have we wear lots of hats, so I totally understand that about 10% of respondents put love to, but I'm already overloaded. And I think it's also really understandable that a lot of people aren't comfortable with diabetes management. We had about 12% of individuals commenting on with that response. And I did have a few who feel like I've lost my mind, and those are probably people who know me. So anyway, Dr. Brostrom, back to you.
Thanks. And, to me, the right answer is D. After doing this for 15 years, I'm pretty sure, yes, we have lost our minds. Because this is tough. Implementation science is difficult. Here's a survey we used in the Pacific, and we distributed this survey in 2010. I was able to repeat it in 2012 at our meeting in Palau. And then we had another meeting as part of a regional meeting in Sydney. We were able to take this test again. We looked at diabetes education in our 6 jurisdictions. We found a really mixed picture, particularly early in 2010. People wanted to do it, they're considering it, but it hadn't really been implemented yet. A few more started doing it for some TB cases. In 2015, we saw even more basic education being provided to our TB cases. So we're seeing improvement. It's modest. It's taken a long time, but I think this is how we make progress one step at a time. In Hawaii, when I got there in 2011, I know we'd given out AccuChecks to every TB program, including Hawaii back in 2009, I think it was. I asked my nurse, where is that AccuCheck, by the way? And she looked at me like, what AccuCheck? And then she remembered, oh yeah, we did get one free a few years ago. And there it was in the cupboard, still in that nice bright packaging where it had sat for a couple of years. Well, we got it out and used the flip chart. Here the nurses are training each other on how to use it. There's Bonnie Young, our CSTE fellow, on the right. She's doing DOT with it there. And what we found is that that the diabetes education with additional work to do glucose monitoring in clinic, that looking at A1Cs every 3 months while we were treating them, we found a remarkable drop in A1Cs. Now, some of this is because this drop is because we're treating TB and the patients are feeling better, so that the acute phase reactant component of glucose and hyperglycemia is managed. So we expect it to come down. But we also remember that these patients are gaining on 10 to 15 pounds each, and to have improved glucose control while patients gain weight is almost impossible. They're on rifampin, which elevates their glucose. Their diet has, their energy and their diet has improved. So I think some of this is what we're doing. It's pretty hard to tease this out. Our data really didn't support our ability to tease it out. But I like this, and it's important to know that a drop in A1C of just 1%, so we averaged 1.5%. A drop of just 1% is associated with a 40% decrease in risk for nephropathy, eye disease, strokes, and heart attacks. This is really important work. Is it long-standing? Did it stay down a year later? We haven't gone back to check on these patients. Frankly, I'm kind of afraid of the truth on this one. But we do have an opportunity, maybe even an obligation, to talk about diabetes with our TB patients that have TB and diabetes. This is a clinical and a lifestyle disease. We have 130 encounters with these patients in 6 months. Let's not waste that opportunity, right? This probably is by far the patient's best chance to implement lifestyle changes, to get the education they need with repeated messaging to improve their condition long term. The TB is going to be cured. They're going to be left with the diabetes. And even I think there's opportunities when you're doing virtual DOT, the electronic DOT, especially if it's synchronous and the nurse is on the line. It's okay to ask them, did you take your diabetes meds today? Did you go see the doc that we talked about to manage your diabetes? And to sort of reinforce the diabetes component, not just the TB component during DOT. Come on, we can all do this, right? There's still question about whether if we improve glucose control, does it lead actually to TB outcomes? And a big ambitious project was taken by Ajay Kumar and the folks at the union. They looked at 2,000 articles, but the data quality was pretty poor. And there were a couple of studies that showed fewer bad outcomes, one in India, one in Peru. But in general, there's limited data quality. Bad outcomes are rare events. It's going to be hard to demonstrate that when reduced blood glucose is going to actually improve the immediate TB outcomes. But in the Pacific, we've been doing universal screening for a while. We've adjusted case management, we extend treatment, and we use TB programmatic efforts to improve self-management. It's a little easier. Our programs are smaller. The TB nurse is the diabetes nurse. The TB doctor is the diabetes doctor. And although we have looked at a drop in TB deaths in the Pacific since we've really begun to pay attention to the diabetes issue, I wanted to look even more closely to see where are we really having those improvements in survivability. And remarkably, I think we're seeing most of the improvements, 40% improvement in death during TB treatment among people with TB and diabetes since instituting these standards and this programmatic management of TB and diabetes. This is not necessarily because of what we did. We don't know that. That's really hard to tease out. But I do think it's a remarkable coincidence that our programs have really stepped it up, and we're seeing measurable drops. We need to look for the more recent data, and particularly when the RVCT 2020 comes out, and we're adding more TB data or diabetes data. That's going to be important. Let's finish up with TB and prevention and diabetes. We know, we all know that the only way we're going to get to TB elimination is to treat active and latent TB. Now, this is interesting study from Matt McGee and his group in Georgia, and they're looking at the refugees, and they're finding that, by the way, you're more likely to have latent TB, at least among these refugees, if you have diabetes, remarkably even for pre-diabetics. So the person with diabetes may have, at least in this cross-sectional evaluation, a higher prevalence of latent TB in that group. What about just going ahead and finding all the diabetics and lining them up and let's give them all LTBI and we can make this problem go away? Well, unfortunately, there really is no evidence to show that diabetes is an important priority for global latent TB infection screening. And CDC really has avoided recommending LTBI for every diabetic in the country. And I think that's smart. I don't think we should. I think we need to look a little more carefully at who should get the prevention, and not just prevent everyone that has, provide prevention for everyone with diabetes. Both CDC and WHO discuss the possible importance of diabetes as a very important second TB risk factor. And by the way, those recommendations are both based on a lack of studies. So it's not like studies are showing it's a bad idea. It's just there's no studies that have really shown it's a great idea. There's just nothing. We do know a few trends that can help us. One is that the younger people with diabetes seem to have a higher rate of TB. There's a study done in southern Mexico. And among the 20 to 44-year-olds in clustered cases, you can see the relative risk of TB is 18, so 19. It's close. That's close to HIV levels. So there's a higher risk of relative risk of getting progressing with diabetes for the younger people. They seem to be at a high relative risk. That maybe it's because they're closer to their initial exposure. Maybe no one really knows for sure why this phenomenon occurs, but it's reproducible. Other studies have shown the same thing. And younger people, luckily, could tolerate their latent TB infection better, and they're going to realize more lifelong benefits from taking their latent TB infection treatment, presuming re-exposure is not a major issue. We're trying to capture this risk in our TB center in Hawaii. We have a TBEST sub-study group, and we're looking at trying to screen and prioritize people for prevention with diabetes. And we tried to figure out how to implement diabetes control. And some of that's based on this study that came out of California, and they're looking among their foreign-born individuals with latent TB, all right? So this is our target, foreign-born latent TB. Do they have a second risk factor? And they listed these second risk factors: transplants, Crohn's disease, end-stage renal disease, HIV, rheumatoid arthritis, and one more second risk factor was present, and that was diabetes. So among the foreign-born with latent TB, if you're looking for a second risk factor, diabetes is the one you're going to find most commonly. So in our clinic, we're trying to bring some science to this and use that old TB risk stratification, TB in 3D from Menzies group, and we try to set that bar at 5%. And if they have a more than 5% lifetime risk, then we definitely want to treat you as a priority in the TBEST clinic. Now, some states are setting that bar lower at 3%, so that they're going to have to do a lot more prevention. And that's a great idea if you have the resources. So I think California is doing this at 3%, and Colorado's at 3%. We're picking 5. We want to do it well, really well, and then maybe we'll think about lowering it afterwards. But what you find is that if a patient's under 25, you have to prevent their TB if they're foreign-born. For us, mostly from the Philippines, their rate is more than 5%. You got to treat them. But if they're over age 25, then really, if you're going to hit 5%, you almost need a second risk factor. So if we look, here's someone from the Philippines, 45 years old, with TST and 3D, and their risk is 3.4%. Here's the same patient. We've added diabetes. Now the risk is 9.5%, almost 10%. This is now somebody we would definitely want to give latent TB treatment to. But how do you do it? We've also found, by the way, that diabetes is unknown. Unfortunately, just like in TB, you have to test them. So we found a way to do this quickly and inexpensively at less than $2 per patient. Our quick analysis showed that even though we do 17,000 evaluations for TB every year in our clinic, we'd have to do about 10 glucoses and 1 or 2 A1Cs a week to be able to use this kind of science and sort our patients better. We're going to try to implement this. We'll see how it goes, and I'll let you know. Again, when we looked at this, this is just the number. We combined our data with Maricopa, who is very helpful. Renuka and her group, Ari, found that together we found that most of the patients actually didn't know they had diabetes. That's not very surprising. And if you add the pre-diabetics, then even in latent TB screening, 40% of people had some sort of glucose instability. For those that were coming from, for us from the Philippines and from Maricopa, they actually had quite a number of folks who were refugees. So it's hard to summarize that. The data's still sort of unclear. But in the midst of this cloudiness, I think in general, people are looking for recommendations. And in the Pacific, we've asked people to screen any diabetic who's under the age of 50. And for us, maybe foreign-born people with diabetes with poor glucose control. Do it. And if they're negative, you can repeat that every 2 to 5 years, depending on the local epidemiology. We're always asked about TST versus IGRA, and the IGRA and TST both seem to work pretty well until that diabetes is advanced, and then the IGRA may have some advantage. Okay, whew. It's time for questions. Program collaboration is important. Let's have a discussion very quickly. I think it's hard to take that first step, isn't it? It's hard to take the first step with TB and diabetes. And I think one of the most important things is to sit down and have a meeting. Have a meeting with your diabetes program and choose a pilot site, decide where you're going to do some screening. This is a good thing to put on your TB report every year, folks. Meet with your diabetes program, find a site, but make sure you decide who's going to pay for the TB screening and who's going to perform the TB screening. Many programs go thinking they're going to go teach those the diabetes clinic nurses to do the TB screening. It rarely works out. I think oftentimes it's incumbent on us to get out there and do the screening ourselves. And then how are the screening results going to be recorded and communicated? Let's keep track of what we're doing. And then, of course, the ultimate question is making sure that we're not just testing a bunch of people, and we want to make sure that we treat everyone to completion. Okay, almost done. From the International Union meeting in Liverpool, this was the topic was confronting resistance. This was the main purpose of that meeting. This was the theme. And we're talking, of course, about TB drug resistance and what we're going to do. But in the end, let's face it, we were talking about more than that. We're talking about our own resistance to change, our own resistance to improve treatment based on what the patient needs, the patient who's in front of us, who may have two diseases, not just one. So we have to integrate. And of course, our goal, we're TB people, we want to control the glucose during TB treatment. We refer people to primary care. We may do glucose monitoring, even in clinic. Come on, we can do it. Basic diabetes education in TB clinic, come on, that's free. We can do it. Diabetes meds with DOT, maybe even, you know, did you take your metformin today with the video DOT? There's ways we can do this. And hopefully we're going to improve our TB outcomes. I'm not sure we're going to be able to measure that. It's pretty subtle improvements. But I do know this, that we need to share the core goals of diabetes, that these NCDs are here now, they're here to stay, they're going to be a growing part of TB, and we have a responsibility with all those home visits to try to improve diabetes outcomes long after the TB is cured, okay? So with that, finally done. I don't think I've ever done a talk that lasted more than an hour. I apologize, and I will turn it back over to the moderators.
Oh, Dr. Brostrom, thank you so much. That was just really a phenomenal talk. And I think we've gotten quite a few questions and a number of people also commenting on how much they appreciated the information you shared. I also want to thank you for the encouragement. You're down there in the trenches. You're in a high TB risk, high diabetes risk part of the country. And you know, you are finding ways to make this happen and have an impact. So I'm really, really delighted to have that encouragement that we can do it. So I would like to ask you some questions. And while I'm kind of pulling together questions from the audience, one thing I did want to ask you to elaborate a little more on is the treatment of diabetes in patients who are also going to be taking TB medications. And in particular, you know, you mentioned metformin. Could you talk just a little bit about its importance in patients with TB and diabetes?
Sure, I sort of expected we were going to get some questions about metformin because there's some recent papers that have been completed, you know, initially showing that in mice, when they, even the non-diabetic mice, when they got metformin, the TB seemed to cause less lung damage. It really confused people. It's kind of exciting. And then there's been studies recently looking at large populations, and sure enough, metformin seems to improve TB outcomes, actually irrespective of glucose even. A great study done in Taiwan, and it showed a 70% reduction in death for the TB diabetic patients. 70%, imagine that. Whether that, you know, that kind of work needs to be verified and repeated with a randomized controlled trial. But the early indications are that metformin has a really important role, or may have a very important role in patients. You know, we're not advocating for 5-drug therapy yet. Right? I'm not allowed to say that, but it seems like it's sort of an essential component of TB diabetes management, and it's the mainstay for diabetes anyway. I mean, everyone that has diabetes and has the slightest bit of glucose elevation probably should be on metformin anyway. So, you know, the TB program can probably encourage that with the primary care doc to make sure that patient is on metformin. But interesting stuff. And there's another study that's looked at culture conversion for cavitary patients. They convert their cultures more quickly if they're on metformin. So there's lots of work that's being done right now to sort of unlock the mystery of how metformin is having an effect. And again, that effect probably has to do with that complicated immunology thing where the diabetic monocyte is hyper reactive and causing autophagy and more cell damage than it should.
Thank you so much. A number of these patients that will be coming to us will be born outside the United States. You know, many of our Hispanics that have TB and diabetes may be undocumented and unable to access healthcare and treatment for the diabetes. So do you have suggestions? And I know that resources completely vary depending on where you are and your setting and your state, your local resources, but are there any organizations or any recommendations you can make as to where people could get assistance with their diabetes treatment while they're on TB therapy?
Yeah, this question is going to make me cry because I think it's unanswerable and it's really important. And we struggle with this in our clinic in Hawaii too, linking our patients to primary care. It's an age-old problem with our TB cases who are often disenfranchised and not connected well to primary care with our complicated medical systems in the U.S. But I think it's important. I think, this is, I'm going to kind of wiggle out of my answer by saying the lifestyle changes, the improving in the diet, the checking of glucose in TB clinic, it can have a remarkable effect on our patients. And for our patients that we did actually a look at knowledge attributes before and after for our TB cases. Bonnie Young did this work with us, and she found people really, really appreciated our nurses, our TB nurses and our DOT workers sort of going there and talking to them about their diabetes. It's much, for most of them, even those with insurance, it was much more intensive, patient-focused work than they got from their primary care docs. So just talking to them about their diabetes, these lifestyle changes are probably more important than whether they're on glipizide or one of the fancy, thioglutamines or whatever. These lifestyle changes are important, so we can at least do that. And whether we're handing out metformin in diabetes or in TB clinic, like we did in Saipan for many years, we're probably a long ways from being able to do something like that. That's not really recommended. I think we just got to keep working on getting them a primary care visit and work on those lifestyle changes.
Thank you. I want to highlight that if our participants will look at the control panel, we have put copies of these slides there, but we've also put that the Union Guide for Managing TB and Diabetes there. You guys can just download it directly from this webinar. And Dick, if people would like to look at the Pacific Islands standards that you showed that are, kind of pointing out some guidances that can help help providers manage patients with TB and diabetes. Are you willing to share those if they reach out to you?
Yes. Again, I need to make it clear these are not CDC approved guidelines. I haven't gone through that review. There's sort of a local peer review, some help from Curry, but not a national peer review. But yeah, I would love to. I'll send you the recent version. I think the link goes to a version being held in the Pacific, and it's a bit dated. So I will send to you the most recent version. I can do that right away. And if you could include it in the packet, that would be wonderful.
Okay, yeah, that's great, because I know that programs like to share with each other even when CDC is not involved, and those are some of the best ways that we can all improve our care together. I'm seeing quite a few questions kind of going back to this issue of testing patients with diabetes, screening them for TB and LTBI, and also screening screening TB patients with hemoglobin A1C. So I guess the first question is, if you could reiterate, how important do you think it is for programs to try to add in a hemoglobin A1C, a diagnosis of TB, or are there certain groups where you would say prioritize, for example, foreign-born Asians or, overweight people from, certain jurisdictions, certain ethnicities or countries? What would you say about that, when to prioritize hemoglobin A1C screening?
Well, that's a brilliant question. I think operationally, it was much easier for us to just put it in a test for diabetes in the intake for an active case. So when someone comes in and they're going through a TB workup and they're getting the regular blood draw, to add, glucose is usually there anyway. We added an A1C. And so there's two questions: which test to use, and I strongly recommend the A1C. I think there's transient hyperglycemia that could confuse us and cause overdiagnosis. That's much less likely to happen with an A1C. So I like that test better for diagnostic purposes in someone who's sick. And then secondly is who should be tested. And, you know, rather than have the program sort of sit and figure out risk factors, there aren't that many TB cases we're processing. It's not that hard to just put it in the routine and not think about it, because, you know, we're going to find lots of them in low-risk populations. People need to know if they have diabetes. You know, to me, the only question is, if they already know they have diabetes, would you add the test? And I'd like to, because I want to know how bad is it. But I think, to me, that's the only group that I would consider not testing, are individuals who already have diabetes. If I'm in Utah and I get a TB case and there's I would still do universal testing for an A1C on everyone who comes rolling through with TB.
What about when would you repeat it? There was a question of if you get it at baseline, you see that it's fairly out of whack and indicating poor long-term glucose control. When during TB therapy would you repeat it?
Well, for diabetes, the standard is every 3 months. And so we wouldn't expect, it changes slowly, sort of like, you know, a thyroid test. You don't expect the change to occur right away. So doing it in 2 weeks is not going to help you. To me, I would stick with 3 months and recheck. Now, in the meantime, you know, that A1C helps the TB program to know how the patient's doing. What's really helpful to the patient is to know what the glucose is. And it's part of the visit in clinic. If you're poking their finger and saying, wow, your glucose is 183 today, what did you eat for breakfast? You know, that's the teachable moment with immediate feedback that goes to the patient, and probably is more to do with lifestyle changes than telling them that their A1C is gone from, you know, 8.3 down to 7.8. So that glucose, I think, is more informational for the patient, if the program can find their way clear to do some testing during the clinic visits.
Thank you so much. Are there certain patients with LTBI for whom you would go ahead and, if they don't know they have diabetes, you would go ahead and get a hemoglobin A1C?
Wow, so we're really deep in the weeds here, and
Yeah.
this is an important question, though, because we, you know, sorting risk and trying to bring science to this monster pool of people with LTBI. Really, you know, we're all trying to face this now. So for us in Hawaii, I think we haven't settled finally on what we're going to do. What makes sense to me is to, if someone comes from and they're foreign born and they're getting LTBI testing, and they're over age 30, and particularly if they're foreign born from an Asian country, I want to know their diabetes status, because it's going to guide me about whether or not they're a priority or a super high priority for someone that we want to do the full court press and make sure they're on 3HP or 4R and get them their LTBI. You know, we have to try to bring some sort of typical TB guideline-based approach towards this LTBI challenge that we're all really starting to face up to.
Yeah, for sure. I see that Dr. Maras at CDC has commented that all type 2 diabetics should be on metformin, but not necessarily type 1. Do you agree with that?
Oh yeah, and I think that's an important thing. I'm glad that question has come up, because almost all of what I was discussing here relates to type 2 diabetics. Type 1 diabetics, who certainly do have a higher incidence of tuberculosis as well. They require much more intensive management, and I would definitely be working, if I had a type 1 diabetic come to me, I would definitely want to be working with the endocrinologist to help me manage that case. I would, and most of these recommendations are for the predominant type 2 diabetic.
Yeah.
Thanks for that question.
Yeah, no, and thank you, Sapna. So I've got a few more questions, but it's 12:30. So I just wanted to tell the audience, if Dr. Brostrom can stay on for a few more minutes, we can ask a few more questions. If the audience members need to leave, we thank you for participating. In about a week or so, we'll have a link to this recording and post it on our website. And again, don't forget about the handouts, and also to fill out the, I think you get a post-webinar evaluation. So let me just ask you if you have a few more minutes, Dr. Brostrom. I love this question. An outreach worker has asked, as an outreach coordinator in San Diego, I'm trying to incorporate TB 101 into current diabetes education curriculum with the Asian Pacific Islanders as well as Hispanic patients. It's not the easiest sell. What would be your 1-minute elevator speech condensing a health educator that this is important?
Well, I can't give you an eloquent 1-minute elevator speech. Feel free to download 1 minute of that of any of the 75 minutes of that last presentation. But I do think that there are definitely some points that you want to bring in your diabetes education curriculum, and the first is recognition of TB symptomatology, early recognition, and early seeking of treatment for symptoms that may be more subtle than in other patients. So I think that a reminder that when their glucose is in good control, it protects them from TB, and that which should encourage them to maintain their glucose in good control. I think, by the way, that work there is just heroic. To do diabetes education work and to incorporate TB, I think, is fantastic. Thank you for considering putting that into your curriculum, and please share it with the rest of us when you get something that's working well for you.
Yeah.
So those are the main comments. You know, med compliance, glucose control. If you think you're already at risk for TB, if you've been exposed to someone in the household, make sure you take your preventions, you know, to give them those prevention messages. It's easier to take now. They're going to do very well with it, and they can have an opportunity to protect themselves.
Great. So I've got a question from one of our excellent clinicians in Alabama asking, does rifampin increase blood glucose independently, or is it due to interactions with the diabetes meds?
I love this question because I took a look many years ago at some, Google's a dangerous thing, Google Scholar, and I found some old papers where they took a bunch of medical students and gave them rifampin and then measured their blood sugars. And they did find that rifampin independently of diabetes will increase your blood glucose, okay? In addition to that, it definitely interferes with many of the diabetes meds, although most prominently, as we mentioned, with glyburide. Not much of an interference with metformin, and no interference with insulin. So the answer is yes. Independently will elevate your blood sugar.
And I believe there's a drug-drug interaction. An interaction where the quinolones can also affect blood glucose during TB treatment, of MDR treatment. Is that correct?
I haven't. I don't have that one off the top of my head, so I'm sorry. I wouldn't be surprised.
Yeah. And one other thing about medications that I wanted to point out, because we do manage quite a few patients with TB and diabetes, and a number of these patients have got increased incidence, I think, of gastrointestinal side effects, and also, you know, even up to vomiting. And then there's always this issue of non-adherence because of those symptoms. And we will often use Reglan in conjunction. We'll give it about 30 minutes before we give our TB medications, so that helps increase the gastric, helps move it through the GI tract, so that these patients don't have the pills sit there if they have some gastroparesis, and then don't end up being able to vomit as easily, and it may improve symptoms quite a bit. Has that been your experience as well?
Yeah, I think Reglan is probably an underutilized agent for us, both in the non-diabetic, or the diabetic and the non-diabetic patient. But gastroparesis and poor gastric motility and emptying, I think we do see increases in nausea given TB meds. So that's a great idea. Thanks for sharing that one.
Yeah. Another question is about extrapulmonary TB cases, and if there are any recommendations for length of treatment for extrapulmonary disease in an elderly diabetic patient.
I think monitoring response to treatment, which is difficult, of course, in an extrapulmonary patient, even if it's scrofula, and even if it's palpable, it's still difficult to monitor it, to the true response to treatment, because so much of that is immune response and not the presence and activity of the tuberculosis. So it's as far as I know, there are no recommendations that would extend to prolonging treatment for those that have extrapulmonary TB over and above what ATS, CDC, IDSA standards are right now. I think, however, that comment that we talked about where patients that have poor glucose control, consider extending to 9 months. And I would definitely, particularly in a patient where you can't really monitor how well they're doing during your treatment, I would use that as an excuse to extend treatment if their glucose was not well controlled. So particularly for an old person, I think better safe than sorry, because those relapse rates lead to, we know, increased rates of TB resistance and more difficult second round of treatment. So I tend to would use that glucose control to help me decide if I want to extend a treatment.
Yeah, that's a great answer. After we discussed the Reglan, I received another question about Phenergan for nausea. And the patient is diabetic. I think that would certainly be a good idea if patients have nausea. The benefit of Reglan is that it also increases the gastric motility, or moving things through the stomach faster, which I think is really also helpful for nausea. What do you think about that?
Yeah, I think, when it comes to nausea, it's, we trial and error with everything we can because it's so vexing for our patients. And it definitely affects our success rate. So for us, it might make sense to use Reglan first, but then to use Phenergan or even ondansetron if we have to try to improve nausea in those patients.
That's great. Well, listen, I think probably we've helped people as long as they can last. And we're just, again, I want to thank you so much for being one of our speakers. This has just been a fabulous, fabulous presentation. And I'm seeing lots and lots of comments on the questions saying thank you, mahalo, and other things as well. So Dr. Brostrom, thank you so much. I'm going to let Linda close us out.